Hi, and welcome to another episode of the Mini Battlesy series by Athens Shoulder Course. My name is Manos Brilakis, and I am the head of the organizing and scientific committee of this course. Counting down only 15 days to the next Athens Shoulder Course in May, 4th to 7th of May, we look forward to welcoming you live in Athens or virtually via our support platform, BMed. Registration are open. For more info, please visit our site www.athens-shoulder-course.com.
So let me welcome you as well. I'm Manos Antonogiannakis. I'm the chairman of the Athens Shoulder Course. So every month for the last 2 years, we had a mini battle between orthopedic surgeon, friend of ours, who talked, discussed, share opinions about interesting shoulder problems. And now this is the last mini battle before the fifth Athens Shoulder Course, and we are excited and anxious waiting for the heart of shoulder surgery to be in Athens next May. So, before introducing our guest, let's take a moment to vote for our question.
The first question, the first and the only question is that as far as the reverse shoulder arthroplasty approach is concerned, which is your preference? Do you prefer the deltopectoral approach or lateral approach or any other approach? Feel free to answer, and today's episode is dedicated to the surgical exposure of reverse shoulder arthroplasty. And with us, we have three very dear friends and exquisite surgeons. The fourth of the company, Philippe Clavert, unfortunately is not with us because of a flight delay. Now Philippe is traveling over some ocean, and we wish you to have a nice flight. So let me welcome Associate Professor of Orthopedic Surgery at Loyola University in Medical Center in Illinois, Dr. Nickolas Garbis, Professor Dr. Georgios Arealis, Consultant Trauma and Orthopedic Surgeon, Shoulder and Upper Limb Specialist at the East Kent Hospital University in the UK, and Professor Dr. Ofer Levy, Consultant Orthopedic Surgeon, Professor of Orthopedics at Ben Gurion University in Israel, Director at the Reading Shoulder Unit in Berkshire Independent Hospital, and also Director at the Israeli Shoulder Institute.
So, welcome to this mini battle episode, the last one. And throughout all this mini battle discussion, opinion sharing, you can you can send your questions, and we are going to have a lot of time at the end to discuss about the best approach for reverse shoulder arthroplasty.
So, without further delay, let the mini battle begin. Nickolas, you can do your presentation.
All right. Hello, everybody. It's in Chicago. It's early afternoon for us. Hope you're all having a nice evening if you're joining us from Europe. So today I'm going to talk a little bit about why I prefer the deltopectoral approach for my reverse of shoulder arthroplasty. My disclosures are updated on the Academy of Orthopedic Surgeons website, and I have no real pertinent disclosures to the topic of this talk. Some preliminary things I'd like to get out of the way first. One, I grew up and did most of my training in the United States. So this means that by default, I did most of my training using the deltopectoral approach. It's more common here. There's a few centers that do more deltoid split or anterior superior approach, but by and large, it's mostly deltopectoral approach. On the other hand, I'm also Greek, which means I'll argue about anything. So I'm happy to proceed arguing my point. So selecting an approach, you're left with, as a surgeon, you have several choices. I mean, you have similar discussions in regards to something like hip arthroplasty when you're talking about doing anterior, posterior, direct lateral approach. So what are the things that we look for in a surgical approach? So, there's some considerations. There's reproducibility. Is it easy to teach? Myself, I'm at a university center, and we have some trainees, and there has to be some ability to teach certain approaches. Low intrinsic complication rate, so you want to avoid specific complications if you can that are secondary to your approach. You want to be able to optimize your surgical result, and you also want to be able to discuss, if it allows for a plan B. I'm sure you'll hear viewpoints from both myself and George today about why we think that our idea is better, but I'll try to put forward my points. So, reproducibility. So clearly, the approach you're most comfortable with can be reproducible with repetition. And in all honesty, most people who perform shoulder surgery are comfortable going with either approach. Everybody's going to be comfortable with doing the either deltopectoral approach, or if you're talking about doing an anterior superior approach where you're taking the deltoid. Obviously, the more you do of one, you're going to learn the tips and tricks and pearls that sort of make it work better in your hands. And I think it's important to understand that sometimes it takes a little bit of repetition to be able to perform it efficiently. Moving forward, I think the teachability-wise, the deltopectoral approach is simple and useful, and I mean as the anterior superior approach is going to be as well. I'd make the argument, though, at least in my situation, I feel more comfortable with my trainees here proceeding on the deltopectoral approach at my institution. I do superior approaches, superlateral approaches, or anterior superior approaches rather, often enough. But those are usually ones where I'm not letting the trainees do it. Now, with that being said, we don't do a lot of them here, and they don't tend to see that approach a lot, which is probably why I'm not as comfortable kind of letting them do a little bit more on that. But at least in my situation here, the teachability of the deltopectoral approach is applicable for more things that my trainees might be doing. Complication rate, and this is where we start to discuss some of the differences. These approaches. We know that a patient that's well indicated that gets a reverse shoulder arthroplasty is going to do usually very well, regardless of the approach. They're going to be happy with their pain relief. They're going to have good constant score, usually good postoperative outcome. But with some different considerations in regards to the approach, there's maybe a higher dislocation rate for the deltopectoral approach. And there's also consideration for potential higher base plate malposition in the anterior superior approach. Now, if you talk to somebody who does lots of deltopectoral approaches, they're going to tell you, well, my dislocation rate is really not all that high. And if you talk to somebody who does a lot of anterior superior approach, they're going to tell you that their base plates are perfect every time. So I think that that's why this is one of those interesting questions where there may not necessarily be a right answer. Now I'm going to throw something else different, and this might be comparing a little bit of apples to oranges, but even when doing a head-to-head comparison for at least for the proximal humerus fixation level 1 data, and granted this was for fracture, it's a little bit different. They're using a locking plate. This was a Journal of Shoulder Elbow Surgery. There was actually lower postoperative outcomes in the patients that had the deltoid split, and the only thing they changed in that situation was the approach. And then the similar paper in 2014, this was the level 2 study, that actually showed no difference. When you look at the literature comparing deltopectoral approach to anterior superior approach, really a lot of the data is all over the place. I think that it's pretty clear there's likely a higher dislocation rate in the deltopectoral approach. Some series quoting even close to 5 times, 3 to 5 times what you'd see in the anterior superior approach. Some of that data is a little bit older, and the implant morphology maybe has changed a little bit. And that sort of it'd be interesting to sort of see a newer study using newer type implant methodology and see if it's any different. There are several different good points for the deltopectoral approach, and certain things that we do try to get the maximum benefit out of using that approach. So it does preserve the deltoid. The deltoid's the motor for your reverse shoulder replacement. The other thing is it's quite easy to get to the bottom of the glenoid. That's a little bit more difficult in an anterior superior approach. Although somebody that does a lot of them can usually have enough tips and tricks that they can get down there. The other thing, if you're going to do a latissimus transfer in a modified Lepiscope fashion, it's a little bit easier to do it from a deltopectoral approach, and it's also an extensile approach. You can basically just continue your incision straight down the front of the arm and convert it to anterolateral approach of the humerus. You can go all the way down essentially to the anterior elbow, splitting the brachialis. So there are some cons. You need to take down the subscapularis. Usually there's potential instability. There are some people that will talk about doing a subscapularis sparing approach through the deltopectoral interval, and that's something you can do if you'd like, particularly in patients that don't have a superior cuff because the shoulder is a little bit more hypermobile. You do need to do a capsular release again to get the humerus exposed out of the way and then give you access to the posterior glenoid. If it's a tight shoulder, it's a little bit more difficult to get to the posterior glenoid, and oftentimes you can sort of be pushed to put your centering pin into anaversion because the humerus is in the way and you don't have enough exposure to get the humerus out of the way. So there can be some difficulty getting the posterior glenoid. And in the end, though, like I said, deltopectoral approach, we know how important the deltoid is to our reverse arthroplasty. So why are we cutting it? And also, does it allow for a plan B? How do you approach extensibility in cases of revision? It's certainly possible to split the muscle again. You can combine it with some sort of a low deltopectoral or a anterolateral approach from the front if you need to go in there. There's some concern for the deltoid. If you can go in and continue to split the deltoid and then keep taking it off the acromion, you run the risk of having it not heal. Deltopectoral approach is relatively easy to extend into anterolateral approach to the humeral shaft, such as this case who showed up in my clinic a couple of weeks ago, and I did a little more than a mini battle with him yesterday, getting his infected cement plug out of his elbow, but this ended up being a very big exposure in the front of the arm. So. And what I alluded to earlier, certain pearls can be useful in obtaining complete exposure, and each surgeon will develop their own method to improve their efficiency. And I think that sharing information about how people do things is key to optimizing outcomes. Skin incision, I usually do some coracoid aiming down the lineup of the biceps, usually 8 or 9 centimeters. This patient, we were actually doing a pec transfer on, so we were making this a little bit bigger. You can also consider aiming your incision towards the axillary crease, but it might hinder your lateral exposure. In a deep dissection, the cephalic vein must be mobilized and released all the way from where it's overlying the pec, all the way up to the clavicle, so you can see the whole thing. And then complete deltoid release is key. Even if you're using a smaller incision, something like 7, 8 centimeters, you've got to release that deltoid all the way up so you can get it back and out of the way, all the way from the clavicle, all the way down to the humeral shaft. Some people will release the anterior third of the deltoid, really kind of push down distally and do that. But I try not to aggressively do that intentionally. And you have to remember that the deltoid drapes over the coracoid a little bit, so the coracoid tip is going to be a little bit medial to the deltoid. You have to mobilize the pec off the underlying fascia to help you get it out of the way. And then separating the interval between the deltoid and the pec, usually like using electric cautery to help me here because you can get those annoying perforating vessels, and there's nothing more annoying than dealing with bleeding during the entire case. I like placing a retractor lateral to the pectoralis on the humeral shaft, and it can help protect the deltoid distally. And then incising the clavipectoral fascia from just above the pec to the CA ligament lateral to the short head. One thing to keep in mind is this Alicia vessels, and when you get the anterior humeral circumflex artery, there's a little branch that takes off from there and it goes right to the deltoid. My retractor is basically positioned a little bit below this. The axillary nerve tends to be at this level here, And there's always a little vessel branching off there. So I do like to coagulate that because, again, you do get that profuse subdeltoid bleeding if you're not careful. This again, I mentioned this was in a transfer, but it's showing where the muscocutaneous nerve is. So, in general, if you're going to put a Colbell self-retainer, you want to make sure you're not pushing so hard on the conjoint tendon that you're causing muscocutaneous nerve issues. Again, this is not an approach for a total shoulder, but rumor has it though that American surgeons hate the subscapularis and we never fix it. But it's probably true. But I don't always fix it. But when I do, it's beautiful. In general, I do try to fix everyone. I think some of the keys to that are to do a subscapularis peel, where I can get the whole thing basically as a sheet of tissue off of the humerus. It really allows you to get inferior retractors to protect the nerve and allow osteophyte resection, particularly those stiff patients where you might be dealing with an osteoarthritic who you're doing a reverse for. So both approaches can provide excellent results for patients. I think it's important to assess your own comfort level and be facile with both approaches. And for me, it's more familiar, provides acceptable rate of complication, and I think it's more versatile for complex cases. Thank you very much.
Thank you, Nickolas, for this interesting presentation. Let us now listen to what George has to say.
So, George, you have to unmute.
Can you hear me?
Yes.
Yes.
Let me go to full screen as well with my slideshow. So thank you very much. I'll share my ideas about how I prefer the lateral approach. And it could also be, if you remember the old Western, about the good, the bad, and the ugly in the approaches in shoulder surgery for reverse. So when we talk about the lateral approach, it's not the direct lateral split, which is very commonly used for fractures. It's not the deltopector, it's the anterosuperior approach. And this one has a name. It's called the Nervazy-Mackenzie approach. And there is a bit of a legacy into it. So Mackenzie described it based on Nervazier's original paper. And then Professor Copeland took it to the thoracic shoulder unit. Prof. Levy uses this a lot. And as a fellow there, I was trained to do my shoulders and my shoulder replacement using this approach. We did quite a lot together, about 115 the year of my fellowship only. This is not an exhaustive presentation of what the approach is, because it has a lot of tips and tricks, but you need your patient semi-reclined, and all the drawings are from the original Mackenzie paper. So we're actually following pretty much the same approach and the same advice that Mackenzie gave us. Then you find the interval between the anterior and the middle deltoid, and you do not cut, you simply split the two heads of the deltoid. You need to be careful how long you go down from the acromion, and this is to protect the axillary nerve, and we'll talk about it in a minute. The third step is where you do an osteotomy, and you take an osteoperiosteal flap from the anterior acromion, where you release the deltoid, and this leads you to the AC joint, which you resect. So you do a Mumford procedure, and this complete the resection all the way, and gives you a very nice approach all the way face onto the glenoid. The next step, and this is extremely important, is to find the fascia and stay within, because this protects you from causing damage to the axillary nerve. And your door, your entrance into the axo glenohumeral joint is the biceps tendon, especially if the calf is intact. You lift the biceps, whatever is in front is subscapularis, whatever is behind is calf. The swabs is because I always use tranexamic acid, and I leave it into the areas that cause a little bit of bleeding. The AC joint is one of those areas, and completely dries my field. The last step depends on which way you want to go. You can proceed with an stenotomy or a peel of the subscapularis. And this is the original approach described by Mackenzie, or you can follow a newer approach where you leave the subscap on and you buttonhole the proximal humerus through the cuff or the remnants of the cuff in the subscapularis. And this is nicely described by Lederman. And this is how it would look if you were to leave the subscapularis on. If you peel it off, it makes the approach slightly easier. And these are the next two slides. And you can see how well you see face on your glenoid. And you can still see the glenoid face on with the implant in. And when the glenosphere is on, again, you have a very good and excellent access and view of your glenoid. What is extremely important, though, with this approach is that you repair the anterior deltoid onto the acromion. Otherwise, you risk weakness and failure of your reverse. Now, is there a bud in all of this? So is there a character that causes problems? Or is any of those approaches really not fit for purpose? There are rumors. There's rumors that the anterior superior has worse access to the humerus, causes problems with implant positioning, causes loosening, may cause deltoid muscle injury or axillary nerve injury. And then the deltopectoral may cause instability, acromion fractures, or makes the access to the glenoid worse. So let's have a look at the literature and then see which one of those are correct. There are evidence that the deltopectoral approach has a high rate of instability, and this is in all published literature, and it increases the risk of having an acromion fracture. And there is evidence that the anterosuperior may have an increased tendency for loosening, but this is not proven. There's no statistical significance between the two approaches. This paper describes very well the higher incidence of acromion fractures, and it attributes the high risk to the fact that the anterosuperior approach with the acromoclavicular joint release and resection reduces the stresses on the acromion. Now, what is the ability to access the structures? There is a difference. The deltopectoral approach gives us better access to the anterior humerus, to the shaft of the humerus, and to the anterior structure of the joint, whereas the anterosuperior gives us a better access to the whole of the glenoid, and this is slightly more important for a primary reverse arthroplasty, but there are limitations if you're going to do a revision and you need to see or have access to the entire humerus. And are there issues with the implant position? And this is one of the things that have been rumored or discussed about the anterosuperior. Both Torrance and Albinger find no significant malalignment. Torres says there is a slightly incidence of increasing the tilt, the superior tilt in the anterosuperior approach. But again, this is not statistically significant or worse, and there is no real clinical outcome that is affected by this. And then does the deltoid splitting has an effect on the actual deltoid muscle? Lederman has a nice paper again, a very nicely written and assessed. It shows that there is no real difference in the deltoid function and the outcome of the deltoid functioning at the end of the procedure, irrespective of which approach you do. And then the axillary nerve injury. Is there really a risk for axillary nerve injury? Yes, there is, but if you perform the approach the right way, there is no significant difference in the EMG studies after both approaches. But you have to protect the nerve. So you have to avoid abduction because you bring the nerve near to the acromion, and we must be careful in short female and Asian populations where the 5 centimeters distance from the acromion is not safe. For those, you either have to use one of the 20 other rules, either 20% of the total arm length, or use this calculation that is presented by Ikemoto, or you have to be extremely cautious while you dissect anteriorly. But what you see here in this, again, paper from Osgur, you can see that the anterior part where we do our split, the axillary nerve splits as well and dives inferiorly. So it does give you a little bit more space. The high risk is if you do a split for a fracture, then the nerve is significantly higher. And it can be even 3 centimeters from the acromion in small patients. Now, other risk, there is a risk of P. acnes, and this is not well proven, not well described, but in this paper by Hudek, it says that there is twice the risk if you do an superior approach than if you do a deltopectoral, because the P. acnes tends to live on the superior of the shoulder. So you need to take precautions and use all of the newest guidelines to reduce the P. acnes load of the shoulder joint. On the other hand, Lederman has this nice paper that says the length of stay is a lot shorter for the anterosuperior approach, and this saves a lot of cost. But this is a slightly older paper. It's 2017. And I have to say that the length of stay for our patients now is rarely more than 2 days in the hospital, irrespective of what approach we use. And he also identified a better function, but this is slightly biased because they are using the subscapularis sparing approach, which means at the beginning they do not need to protect the subscapularis. Whereas if you do another superior with a subscapularis splitting, then this effect will not be that obvious. So is there any of those approaches bad? Not really, because the axis of the humerus, yes, it's worse if you do an superior, but you usually do this for a primary joint, and you have better access to the glenoid, which is important. You don't need to see all of the humerus. Implant position and loosening, there is no proof anywhere in the literature that is worse. And if you protect your deltoid, if you do the approach the correct way and you protect the axillary nerve, there is no evidence at all that these structures can have any problems or a complication. Is there a risk for the deltopectoral approach to have higher instability? The literature says yes, but the truth is again that if you repair the subscapularis, this will completely disappear. The only thing that is slightly worse is the risk of acromion fracture. So you might consider avoiding a deltopectoral if you have a severe osteoporotic older patient that has slightly higher risk of developing this kind of complication. Or you can release the acromion if you want to from the deltopectoral, just as an addition to the standard approach that you do. And the access to the glenoid, if you do the correct releases, the truth is the deltopectoral will get you there. So there is no real ugly, no real bad in this whole situation. The good thing is that there's no difference. So they're all good. They have the same active mobility, physiotherapy, pain levels, everything is pretty much the same. There are no serious complications. And scapular notching we all talk about, but we don't know whether it means anything. It's exactly the same in both approaches. So the anterosuperior, in a few words, has the advantage that it gives you perfect exposure to the glenoid. You have reduced risk of instability and reduced risk of acromion fracture, so you don't need to worry about those and take measures to reduce the risk. It has reduced access to the anterior structures, and you can't extend it, and that is certain. So you have to be careful if you need to do a revision where there's cement near the elbow and things like that. You cannot use this approach, or you need to do double windows. The difficulties you need to be aware of is that you have to protect the axillary nerve, and it has a steeper learning curve than the deltopectoral. So in teaching scenarios, you need more to be able to be confident and do this approach. And all the rest are debatable. Is there a reduced length of stay? Is the position of the implants or loosening more with the anterosuperior? Is the higher risk of P. acnes there? These have not been proven by any of the papers to be 100% certain. So in conclusion, both give us good results, but the anterosuperior is more elegant. So I think in this scenario, we don't have a bad, but we have an ugly, and the ugly is a deltopectoral. And that's why, for me, I prefer to use the anterosuperior for all my primary anatomic and reverse joints, and most of fracture sequela. When I do a fracture, sometimes I have to do a deltopectoral, especially if it extends way down to the shaft, because I want to reduce those fragments and make sure that my implant is solid. But we need to be aware that the anterosuperior is demanding. There's a steeper learning curve, and in a training scenario, you need to wait a bit longer before you allow your trainees to do that approach. So the ideal is if you can mix both in a training hospital, then you produce trainees that are a bit more confident with the shoulder surgery, and that's what we try to do here. Thank you for today, and we all expect in 2 weeks to discuss more things in Athens.
So thank you, George, for this nice presentation. It's always nice to hear you. And now let's proceed with the results of the poll question. Manos,
in the poll question, everyone that attend this session prefer the deltopectoral approach. So George you was very persuasive, and I think that many of the attendants we take advantage of your presentation to start with doing this approach. So, Ofer, George revealed that you use lateral approach. So, which is your comment about the subject?
Well, George presented it very well, so I don't have a lot to add, but yes, I use the anterosuperior approach, and actually George just mentioned, but I will tell the story that we learned it from Don McKenzie, and I thought that this was described by Don McKenzie because there was a paper. And when I wrote the first paper about the Copeland, I called it the McKenzie approach. And everyone since then called it the McKenzie approach until the other paper was accepted to the JSCS. And Bob Neveiser accepted the paper, but wrote to me. He was the editor-in-chief. And he wrote, but I want to correct you, Ofer. McKenzie learned it for me. And I said, and I went back to McKenzie paper in the acknowledgement in the bottom. It was, I acknowledge Bob Neveiser. I said, oh, I'm sorry, Bob. I'll make it right. So since then, every time they call it McKenzie, I correct it. It's Neveiser McKenzie approach. But I think this is an excellent approach. And I just want to say a lot of people are concerned about the deltoid when you do that. Now, I'm just using a little story. As a surgeon, what is more dangerous? A sharp scalpel or a blunt scalpel? Answer, please.
I know the answer.
Yes. In both approaches, you must be careful with the deltoid. And
no, but what is dangerous more? A sharp scalpel or a blunt scalpel?
Well, it's difficult to argue.
It's a blunt one is more dangerous because it doesn't cut. It doesn't cut, and then it cuts where you don't want to. You know.
You are right about this.
And exactly, it's the same with these approaches. So if you do an anterosuperior approach and you make the cut and you make the osteoperosteal flap, you know exactly where you took the deltoid, and you can put it back. And you don't disturb the innervation, you don't disturb everything. We repair it very strongly back, so you can start physiotherapy straight away, and there's no problem with that. If you do a deltopectoral approach and you need to get to the back of the joint, I mean, with your hands on your heart, when you finish a deltopectoral approach and you have to go to the back of the joint, the front of the deltoid is like a dog's meal or something. You know, it's completely crashed. And just, I mean, you know that. We all know that. We have seen that. So one of the major advantage of the anterosuperior approach is that you can access the anterior and the posterior areas of the joint easily. It's important in fracture treatment because you need to get to the tuberosity. I personally don't like to put the plates too much. I do a palm tree technique, which is different, but I do need to get to the tuberosity and to get it back to place. And through the anterosuperior approach, it's much, much easier than through the deltopectoral approach. And we see it all the time that people are doing plating for fractures. They can't get to the back, so they put the plate in the front or offset. So we all see that. I mean, this is part of the problem that, you know, they are limited by doing that. Definitely, I do the two approaches, and when I need to do an extensive approach, I can't do the anterosuperior approach. I have to do the deltopectoral approach. But what you can do as well, you can combine between the two if you need to. So if you start an anterosuperior approach and you see that you have to extend it downwards, you just subcutaneously do a deltopectoral as well and go down towards the humerus. So you can work between the two and work on both. I think, in principle, I know that a lot of people are afraid to go to a different approach, to the anterosuperior approach, and especially Nickolas. I think in America, the American surgeons are very fixed on the deltopectoral. It's difficult for them to change. I don't know why, but you know, I think we should be it's tools. Both of them are tools, and we need to use the best tool for the best results of the operation, of this particular operation. So for me, the first approach is the antro-superior approach. Delta pectoral, I'm using it less and less. I use it only when I need it.
Probably has to do with how many times you have done it. And what Nickolas said in the beginning is when you become familiar with approach, then you learn the tips and tricks, and this makes then the approach easier. For those who were trained in certain training centers using the deltopectoral approach, as for me, for example, I did all my open surgery, or at least most of the open surgery, through the deltopectoral approach. It's very difficult to change to another one. And I remember about the exposure with deltopectoral. I remember Enrico Garbis, and Enrico is a master of the approaches to the shoulder, and especially the deltopectoral approach. I really admire him. And he was saying to me, okay, you can cut the humeral head and then proceed with the glenoid. But let me show to you how you can see all of the glenoids through the deltopectoral approach without cutting the humeral head. And at that time, I really admired him, and I said, okay, this is the way to go. And I followed his tips, and now I feel very comfortable with this. And this is how we do. And
Manos,
the problem was how to do a couplant and do the...
Well, that's it. I want to say that I actually I do a Copeland shoulder, a resurfacing. If I do an anatomic, almost never, if I can use a resurfacing, I use a resurfacing. I almost never cut the humeral head. And George can tell you, he did with hundreds of operations with me. I mean, you have excellent exposure of the glenoid.
It's all of the glenoid
approach. And you have to do a good release. But again, a shoulder replacement at the end of the day is a soft tissue operation. Whatever you use, you have to do a good soft tissue release. And I think from the antro-superior approach, you get excellent access to the glenoid. You see it in face, en face, not on the side. You can go around, you can release everything.
Move all of the capsule, and then the head just falls in the back. You don't worry about the head.
You just push the head posterior inferiorly, and you can do the glenoid whatever you want. I mean, I don't stop to do a release until I can I don't put a glenoid in. Usually I do microfractures, but I don't stop until I can put a glenoid in. So even though I'm not putting a glenoid component on the Copeland, I call it a total shoulder replacement, just with microfracture on the glenoid side.
Yeah, I'll tell you, there's a Gillespie's paper. When looking at it, he did. He's in Cleveland. He did a bunch where he did deltopectoral and a bunch where he did anterior superior, and he was mostly trained on the deltopectoral. And it's interesting, they did have some base plate malposition on their series, and I think that has to do a little bit with the learning curve. But I agree 100% with you guys. I think, like you said, I think it's a tool. I mean, I have one next week, which I know George, you admitted to doing a deltopec today. I'm doing anterior superior approach next week for somebody who's had a prior open cuff repair, so we can manage the deltoid a little bit better.
It's easy. If there's a cuff repair and the cuff has failed, it just pops up.
Yep. Yeah. Stick right up. Right. So I think like you said, it's really important. And to you, Ofer, about the mention of using it for fractures. I think it's also very important because I think it's asinine when you're trying to get these isolated greater tuberosity fractures. You have my trauma partners open it up through a deltopectoral approach. I'm like, what are you guys doing? You make an incision this big to get to a little piece this big, and you put retractors to push the humerus forward, and you're trying to fix it. It just doesn't make any sense. So I think
and the anterior deltoid at the end is smashed completely.
Correct. So I think for at least for my primary replacements. I think certain things like we mentioned earlier, I do try to take care to do a good release and then repair it when I can. I know a lot of my colleagues were used to doing just a subscapularis tenotomy, and then they put a reverse in, and then the tendon is in one spot, and then the stump is at the other, and they're like, well, it's irreparable, they can't fix it. Well, of course, because you left a third of it over on the humerus, and now it's in a different location. It's been distalized. Now, if you're taking it off as one sheet, you can have a better chance at least getting some repair and restoring your stability. So I think
you can balance the teres with the subscap, because the whole biomechanics change. You cannot just cut it and it goes in a different place with it.
And another thing is, again, one thing that I tend to do in all my reverses, and this is part of the secret why we get such an excellent rotations, external internal rotation, is to tension any remnant of the teres, the remnant of the teres, even if it's completely rubbish, just tension it. So you balance again the remnant of the subscap with the remnant of the teres, and you get at least a tenodesis effect, and you get good rotation.
You balance everything. It's a soft tissue procedure, like Prof said. Everything has to be balanced, so front and back, because then you have the deltoid to be able to do the elevation. If the front and back, if you unbalance the front, then the deltoid is in a disadvantage, or just push things in the wrong way.
And again, if you don't repair the subscap, and we know that, then they tend to get not so good internal rotation. That's one of the worries of the reverse. And I mean, I can show you our patients. I'm sure that the George patients as well, they have excellent rotations, both external and internal rotation. I mean, this is a key, because good elevation, it's okay, but what you need for daily activities is good rotations to get to your mouth, to get to your backside. That's the key to have a good outcome. Yes. And I think that's where, again, I think we get these good results. I mean, part of it is obviously the design of the implant that we're using, because initially you have to get a good impingement-free motion, passive impingement-free motion. On top of that, then you need to get the muscles to whatever evidence you have to work in balance and give you the good rotations.
So in order to give some tips and tricks in summarizing the formation discussion, the first thing in deltoperoneal approach is that you should protect the anterior part of the deltoid, because sometimes it's violated. And Ofer said that it is difficult sometimes, most of the times, to reach the posterior cuff. And I think an abduction and internal rotation is a move that you can have greater access to the posterior cuff. So how do you agree with this, Nickolas?
I do. When I do use my retractors to protect the deltoid, I do use a Brown deltoid retractor. I know I have some colleagues who use some smaller retractors, or like some Homan type or some Dara type retractors. But the problem with like a Dara or something like that, when it's about as wide as your thumb and you stick it behind the shoulder and then you pull back on it, what you mentioned, it just cuts through the anterior deltoid. So I think having a broad retractor, like a broad Brown retractor or something that can go behind the humeral head and subluxate it anteriorly while it pushes the deltoid posterior, plus or minus, some people will use like a little moist lap on the edge of that to protect it. And then internally rotating the arm, and then, putting a little pressure lift on the elbow, little subluxation forward. You can usually see, the posterior superior part of the cuff, but it's very difficult to see down below when you start getting like between infra and teres. I mean, you can usually see the infraspinatus coming around, but especially in somebody muscular with a big deltoid, it's very difficult to see it back there.
One thing
I use the Fukuda. I use the Fukuda for the same, which is wide, the wide Fukuda. Again, protects the deltoid.
One thing which is important to remember, that at least with the anterosuperior approach, imagine this is a window, and you actually have to bring whatever you work into the window. So you can actually, by moving the arm, pushing the arm upwards, or turning, rotating, you can bring to the window the area that's of interest at that stage. So if you need to work on the back, you do internal rotation and push it up, and you bring it into the window. And that's again, these are the tips and tricks that Manos you asked for. That's part of it. And to be honest, I teach my fellows for the last 25 years to do it. I don't think I don't see any difficulty in that. Maybe because they're not spoiled by by knowing. I mean, they know the delta pectoral because that's whatever they learn, but it's quite quick that they learn to do it, and I do it very methodically. I teach it very methodically. Try not to cut any corners when I teach it.
Yeah.
So
it's the same with me. So I teach the fellows here the same way that Prof was teaching me. And the truth is they can do both, but it takes a bit longer to be able to be safe to do the the anterosuperior, but not significantly longer. All they need to do is protect the axillary nerve. That's what I need them to learn.
Yeah.
To put their finger inside the bursa and identify where the nerve is, and then use a small suture to protect the deltoid from splitting altogether. As soon as I know they can do that, the rest is safe because there's nothing that, especially if there's no cuff, there's no harm.
The excellent point, George. That's I wanted to. It's good to mention that, and it's really a key, because when you do the anterosuperior approach, one of my previous fellows is a consultant in London, Omar Hado. When he was my fellow, we did a study, on cadaveric study, and we assessed where the axillary nerve sits. And actually, the axillary nerve sits about 1.5 centimeters below the cul-de-sac of the bursa. So when you open, the way I teach everyone to do it is to open the bursa, put the finger in gently. Of course, you can tear the bursa, but you could put the finger in the bursa, and you feel the cul-de-sac. If your incision is still above the bottom of the cul-de-sac, you're safe. And that's your guidance that you are safe, you don't touch the nerve.
And that's where I moved my slides back. I don't know if anybody, are they still visible? No, they're not. I moved them back into where the bursa, you need to lift the bursa. It's important. In that approach, that's the most important step. As soon as the fellow can understand the difference between bursa, cuff, and subscapularis and can lift and find the bursa, then they're quite safe to do the rest of the approach. The rest is not that complicated.
I work with second and third year residents. They're not doing that.
But George, you said you put a suture also.
It depends if you see the deltoid splitting.
Okay.
If you go to the slide, you will see there is there's a little suture. You put a suture at the deltoid, just at the end of your cut, so it doesn't propagate, because sometimes it can just split when you put the retractors and go all the way down. So you put a little tie, and that's part of the Mackenzie approach. It's described there as well. So depending on how tight the shoulder is, if it's very tight, and you see with the retractors, they tend to open the two heads, and the split may go down, or if the bursa is violated, because sometimes when they have massive cuff arthropathy, the bursa doesn't exist, or it's properly destroyed. In those cases, or if they had a cuff repair before and they had a bursectomy, there is no bursa. In those cases, it's a good practice to put a small suture at the end of the split of the deltoid between the two heads, and this will stop it from propagating lower, and that's where you will see the axillary nerve coming down between the two heads. It's safer at the front because the nerve splits in two branches and then in multiple branches. So even if you hit one, most of the rest of the branches will usually survive, but there's no need to take the risk. If you put a stitch, it just stops it there.
Well,
this is the blunt scalpel that you said, Ofer. This is the blunt scalpel.
That's the blunt scalpel, exactly.
Yeah. Okay. But what I'm saying is, and what George is mentioning is, first, if you leave the skin uncut above this line, this will protect you from propagating further. If you, for instance, you use an old incision which goes a little bit further down, and then you are not safe, then I would put a stitch, as George mentioned, to make sure that it does not propagate further. But if you leave the skin uncut above this line, the skin will stop you from propagating further.
Okay. Ofer, if you have an ossa acromiale, do you use the same approach, or do you have some restriction?
Yeah, I use the same approach. I try. I mean, again, not always I can do it, but depends on the size of the ossa acromiale. If it's just a anterior ossa acromiale of the mesoacromion or further. If it's more significant, I will try to repair it at the same time when I close the deltoid back. If it's only the anterior, I'll just take it with the bone, refresh the bone, and repair it bone to bone when I repair it back in a, hoping that it will heal bone to bone later on. The thing is that most of the ossa acromiale, if you start with ossa acromiale before the reverse shoulder, does not have major problem. I have one case which had he had a meta-acromion, actually had no acromion at all, and this guy actually came back after that with dislocations, which I had to reoperate on him, need to rebuild the acromion for him. Then I had to take the plate out. I mean, he's doing all right now, but he was one of my nightmares. Yeah.
So you have seen differences with the ossa acromiale in the post-operative course of the patient?
The majority will not have a problem. Some of them will have a slightly more limited movement, actually mechanically, because the os flips down. I think one of the problems that it's very difficult to repair them with the tension of the deltoid, because the deltoid is tensioned down. So it's what I try to do is I try to put less tension on the deltoid. So I use the smallest liner that I can. So I use 36 head and the 36 plus 3 liner. So I'm pulling it less than, not putting too much tension on the deltoid. And that's in principle, my principle is to not to put too much tension on the deltoid. Yeah.
And the release of the AC joint when you do the anterosuperior approach, you actually cut the AC joint, and that's proven with with a nice paper with lots of data. You reduce the stress on the acromion, and that's probably why you protect your reverses from having an acromion fracture. So if you have a ossa acromiale, that is an indication to go lateral.
Well,
if it's a small one, you can completely resect it and attach the deltoid on the whatever is left.
Yeah.
So you create.
I usually, if there's a sliver of bone there, I use the bone to actually refresh it and put onto the bone again, because bone to bone heals better. Yeah. But George, very good point that George mentioned is the part of the approach is to do a resection of the distal clavicle and open the AC joint, because this gives you much more open approach than if you don't do that, and gives you more access to do whatever you need to do in the joint. And the second thing is why to do it is because most of these patients will have some arthritic changes in the AC joint. Now they may not come to you with symptoms of the AC joint because they can't lift the arm above the horizontal, so they don't really get to the stage that the AC joint is symptomatic. Once you've done it, once you've done the operation, the reverse shoulder, and they get good movement, they will come back with symptoms of the AC joint. Then you have to go back, and so maybe it's not good for business to do it in one case, but that's best for the patients.
Can I say it's an anecdote from my training? So once a patient came with a Copland and a painful shoulder, no movement. So I was at the beginning. I didn't know what the issue was. There was no movement. I was like, So I go to Prof and I tell him the story. He looks at the X-rays. He says, come here. I'll write down what the problem is on a piece of paper. Put it in your pocket. So he put the paper in my pocket and don't open it until I do something. So he brings the patient and injects his shoulder, injects the AC joint. He goes, there's no pain now. What happened? So it was from a different surgeon, and the AC joint was left there. So the patient had AC joint pain, no movement. He was miserable. I was thinking we had to do a revision. What was, and at the end, what we did was an AC joint decompression arthroscopic. I did the procedure, no problem. But it was funny because he said, then open it and see what I wrote. And it said AC joint pain.
Well, it's very common, by the way. We see it a lot, that patients coming with a painful arthroplasty, and as surgeons, we have a knee-jerk reaction to say, no, we need to revise it. And said, hold on. The majority of cases will be either rotator cuff impingement or AC joint before anything else. Yeah.
Mm-hmm. we're looking at our patients that we don't routinely resect through our delta pecs, and when we're bringing them back and a 1-year follow-up, if they have AC joint arthropathy, we're going to ask them if they're symptomatic. So we're going to try to look at them a little bit. So it'll be interesting to see what pans out from that.
That's an interesting question.
No, we wrote a paper many years ago, more than 20 years ago, when Graham Titley Strong was my registrar, and we wrote on arthroscopy for painful arthroplasty. And this was, the first time we said, "Oh, be careful! Not every case is for a vision."
Mm-hmm.
And they used to be the funny ones where you go in with the scope and you see the mirror on the Copland, you see the mirror of the joint, and you see two glenoids. The first time I did, Prof was with me. He would not allow you to do one.
Very, very distressing.
Yes.
Well, I always ask the fellow or the trainee with me. He said, "Hey, what's going on? Why did you put two scopes in?"
George, you mentioned about the higher possibility of acromion fractures with the dectopectoral approach. This is due to the approach, or this is due to the implant positioning, the lateralization, the distalization?
No, that's why I'm saying this is one of the doubtful outcomes. This is using the older Grammon prosthesis, which put a lot of stress on the acromion, and there is clear evidence that the incidence is higher if you use a prosthesis that will load the acromion significantly. But now the whole design has changed, the concept has changed, so I don't think this is such a big issue. But it's good to keep it at the back of your mind that if you do something, so you might still decide to put a glenoid that's inferior and put a thick insert for any reason. In that case, doing a deltopectoral as well will put a massive load on your deltoid. It may be a good idea to go and open the AC joint to reduce the load on the acromion. That's what that paper said. The paper says that there is something that causes increased incidence of acromion fracture, most likely the design of the prosthesis. And the way that they think the anterosuperior approach protects it is because you disassociate the acromion from the clavicle, and then it allows the acromion to sort of gently tilt a bit more, and the clavicle goes upwards.
Yes, probably something this. We didn't have a lot of pain from the AC joint, although I practically never resected the AC joint. Although we see a lot of arthritic joints, we don't see a lot of patients with pain from the AC joint, at least in my practice. And probably this has to do with the design of the prosthesis and all that you mentioned already. Still, when I have a thin lady with a thin deltoid and over 70, I'm very, very anxious how much to tension the deltoid and have to compromise between the feeling of increased stability from the increased tension and the probable pain from acromion stress or acromion fracture.
I must say that with experience, actually, in the early days when we started to do reverse shoulders, we were very much concerned about instability, and we used to put them really, really tight, and then you get all the problems when you put it really tight. And actually now I put it quite sloppy. It's not tight at all. I have to have some movement there, and then you get A, better range of movement. B, you get probably less wear because you're not really compressing it too much. And again, everything I said is it's all dependent on the design of the implants, because you can't compare all the implants together or put them together. Different implants are designed differently. So some of them, if you put them sloppy, they will be unstable. Some of them, if you put them, if the design is that they will be still stable, although they are slightly sloppy. So the prosthesis I'm using is like that. It's quite stable, and I don't see much of instability, even if I put it quite loose, quite sloppy. Yeah.
Nickolas, I know you should go to the OR. So before ending, and give me your best trick for the professional approach.
I think my best trick that I could offer would be what I was mentioning earlier, complete release. Even though, for my smaller women, I measure my incisions to be 7 centimeters, maybe 8 for the deltopectoral. I make sure that I lift up the skin, I release the deltoid all the way up to the clavicle. If I'm not getting that anterior edge of that deltoid off of the clavicle, and if I'm not getting all the way down to the humerus and doing a big bursectomy and really getting that bursa free, I'm not getting mobility of that deltoid that then allows me to shift the tissue and not place a lot of stress on it. So I think that for me is the most important trick.
Okay, George, your best trick for me to start to do your approach?
The best trick I would say is identify the bursa and make sure you don't violate the axillary nerve, because if you do that, then we'll be in trouble.
Perfect. So, do you want to add something else?
No.
In that
So-
case, okay.
Let's
I can add something. I mean, I think we have some videos somewhere on this Vumedi and YouTube or whatever. George did some when he was my fellow about how to do the anterosuperior approach. It's very methodical. So anyone who wants to start to do this, just to watch them, and B, you are all invited to come to Reading, and we'll be happy to show you how to do it. I believe that you can come to Kent as well. And
Yes.
George can teach you in Kent.
But before Reading and Ken, it's Athens in 15 days. And
Yeah, we'll be there.
a lot of discussions, and I hope all of you will be there.
Absolutely.
Nickolas, hope to see you also.
I'll see you guys soon.
Thank
care.
you very
So
much.
this-
Thank you very
So
much.
this is the end. Thank you very much for attending. Hope you
Good
to see
night.
you all in Athens. We remind you that in order to earn the CME points, you have to fill in a teeny tiny questionnaire, which will be sent you by email. You can follow us in the Facebook and the LinkedIn page to stay in touch with Athens Shoulder Course, and follow BMedNet, because there are many interesting webinars and courses hosted in the forthcoming period. So thank you as a guest for attending. Have a nice night.
Thank you. See you soon. Bye-bye.
Bye-bye.